Hello students, I am Dr. Narendran. I am an associate professor from Department of Oral Maxillofacial Surgery from Vinayaga Mission Shankaracharya Dental College, Salem. So today's topic, what I am going to talk about is condylar fractures. So you will have heard about all the fractures of maxillofacial surgery, but condylar fracture is an important fracture that you need to be knowing. I am just briefing it and I have cut shortened it into very briefly on that. I start off with all my classes with a small proverb. Success seems to be largely a matter of hanging when others let it go. When whatever problem you face or whatever issue you face, you stick into your goal where you never lose your hope or at any point of time. So that's how you win your game. So let's go into the subject. So introduction. So condylar fractures constitute about 26 to 40% of the mandibular fractures. A fracture of condyle can cause a significant pain and limitation of jaw movement, thus restricting the important functions of mastication. So first, I think all of you would have been much aware of anatomy, but I'll just brief you on anatomy also. I'll just brush through the anatomy. On anatomy, first you have the temporalis muscle around, you have the articular disc, condylar and the TM joint, the lateral pterygoid muscle and masseter muscle. So these are some of the structures which you find around the condyle. So arterial supply will be, the blood supply of the condyle is largely from the attachments of lateral pterygoid muscle, deep temporal artery, posterior tympanic artery, superficial temporal artery and transverse facial artery. So these are some of the arteries or vessels that you'll come across the condyle. So you don't worry about the vessels or whatever it is around. So you just need to concentrate which the surroundings of these are very specific when you deal with a condylar fracture. It depends on what type of fracture that you deal. So etiology of a condylar fracture it resembles like fall, assault, road traffic accident and sports. So these are the common etiology that will come across condylar fracture. So when you have a mandible fracture of a ramus or whatever fracture on ramus, you will come across, you have to suspect a condylar fracture on it. Okay, so whether some of them just eliminate of this condyle, they say only the symphysis fracture and the angle fracture, but they don't realize about the condylar fracture. So whenever you have a mandible fracture or a midfacial fracture, always diagnose a condylar fracture. So first we go for the classifications. So classification according to Lindell's system is a comprehensive classification in 1977. So Lindell proposed a classification based on several factors. So the anatomic location of the fracture, the relation of the condyle segment to the mandibular segment, the relation of the condyle head to the articular fossa. This is Lindell's classification. So fracture level can be at condylar head. You see the condylar head. First you have the CH is condylar head. Next you have the condylar neck, that is CN, and then the subcondyle. So this is how it is the fracture level goes on. So relationship of condylar fragments of a mandible will be undisplaced, which a fracture, you see a fracture on the condylar region, but it is undisplaced. It is not moved from the anatomical structure of it. And next you have the deviated condylar fracture where the head is slightly deviated. Then you have the displaced is medially overlapped. So sometimes you have medially overlapped and displaced laterally overlapped. So lateral overlap is very rarely you find out, but maximum of condylar fractures you have them medially displaced. Next you have anterior posterior override. Next you have no contact over the mandible. So the condyle is separately over fracture out. So these are the relationship of the condylar fragments of the mandible. So relation of condylar head to the fossa. So when you have the fossa there, no displacement is there. It is the condylar head is still attached to the fossa. Next you have the displacement and next you have the dislocation. So displacement is the fractures only on the head of the condyle, but dislocation is entirely out from the articular disc. So Macklin in 1952 again he classified a separate classification, like it is no displacement, fracture deviation, fracture displacement, and fracture dislocation. So there are several classifications that you come across in condylar fracture, but it is necessary that at least you should know at least 2 or 3 condylar fractures classifications to write in your exams and to do a diagnosis in your radiograph. So here you have no displacement. You see a condyle, bilateral condyle, there is no displacement. You find the fracture is there, but there is no displacement. Next you have the fractures, but it is deviated. Next you have displaced, the condyle head is entirely displaced from the condylar portion. Next you have the dislocation, which is entirely from the articular disc, and you have the lateral view here, and it is on the various views. Okay, it is like from the frontal view, lateral view, and from the view that you see from the occlusal side. From the occlusal view also you have. Okay, so in the last segment of fracture segments, you will find this type of segments. You will find it in the OPG. So this is a rare question which is asked as parade ground fracture. So this fracture is, I want to specify it because why it is called as parade ground fracture is like usually when the soldiers or when you are in your march past or something for a long time, you tend to fall, or like when you faint or you just fall down straight. So what happens when you have the symphysis fracture just touching over, splashing over the ground, you have the both condyles also getting fractured. So this is called as parade ground fracture. When bilateral condyle and a symphysis gets fractured, it is called the parade ground fracture. It usually happens in the army, soldiers or something, so that's why they say as parade ground fracture. This question may be asked as an viva question also. Okay, they may ask you like what is parade ground fracture? What types of fracture that you come across? Okay, so clinical features. So what are the clinical features that you'll come across in a condyle fracture? So inspection is first you inspect this thing. First you have swelling. You can find out with the first you already find a swelling over the condyle region. Next you have a bleeding or external auditory meatus. Okay, you ask thing. Next you have ecchymosis or behind the external auditory meatus. Difficulty in opening or closing the mouth. Limitation of protrusion. Okay, there won't be any limitation. Like see when you feel it over the condyle region, you tell the difficulty on patients opening the mouth. Okay, next you have palpation. You palpate over that. Then you have the lack of condyle movement on opening, closing when you keep the fingers over the TMJ joint. That's how I told you. When you keep the fingers over the TMJ joint, there will be lack of movement. There won't be lack of movement. Okay, there will be a patient will have difficulty in opening it, or patient will have severe pain over that particular region. So there are clinical features differs in bilateral and unilateral fracture. In unilateral condyle fractures, you have shortening of ramus on side of a fracture. So which side of, like if it is right side, you will find the shortening of the ramus on that particular area. Okay, posterior gagging on the ipsilateral side. So you will have a posterior gagging on the ipsilateral side. Deviation of the mandible towards the fracture side on opening. Okay, while opening there will be deviation on towards the fracture side. So limitation of lateral exertion to the opposite side. There will be limitation of lateral exertion towards the opposite side. So for clinical features of a bilateral condyle, so first we saw unilateral, first here is bilateral condyle. Here the shortening of ramus on both sides, posterior gagging, obviously you have a posterior gagging, anterior open bite, limitation of mouth opening and limitation of lateral exertions. So these are the common clinical features. So here in this presentation I have just briefed you in a very short manner to write about or learn about a condyle fracture. So first we saw about the classifications. Okay, so we saw the classification mainly, then we saw the etiology, common etiology that we come across. Next about the clinical features. So we saw it for the clinical features like unilateral and bilateral. So sometimes when you have a question write about a condyle fracture, they will be specifically written like write about the clinical features of unilateral or either bilateral. If they generally write clinical features, you can write both the clinical features of both unilateral and bilateral, but if they specify unilateral, you have to just need to mention a brief thing on a unilateral or a bilateral one. So diagnosis, then you take a proper history and clinical examination over the particular fracture, then you have a proper imagings. So what are the images that you can take for a condyle fracture? First is OPG, then you have the TMJ is called the Townes view or reverse Townes view. It is a specific radiograph for the condyle fracture. Transfacial, transcranial, transorbital views, CT scan or MRI. So these are the common imaging that you will come across in a condyle fracture. So here in this picture you see a bilateral condyle fracture in the unilateral way. So here is a slight movement, sorry about the picture. So here you can find bilateral condyle fracture. My picture is just moved away from here on this thing. So there is a bilateral condyle, there is a subcondyle fracture on both the sides. This is an OPG showing the condyle fracture. So here you have an CT showing a 3D view. So where you see a condyle fracture again, you can see it off. You have a neck of a subcondyle fracture which has been fractured there. So management of condyle fractures. How will you manage a condyle fracture? Usually condyle fractures can be managed either by closed reduction or open reduction. Okay, there are two types of thoughts always in a condyle fracture. So there's a controversy again in whether to operate a condyle fracture or not to operate a condyle fracture. So there are certain specifications where at that point you need to operate it, as at certain point you did not operate it. Okay, so that you need to be very particular when using a condyle fracture. So management is conservative or non-surgical management. When children are under the 10 years of age, that is if required, you just need an IMF for 7 to 10 days. Okay, this is a conservative management for children. But for adults around 10 to 17 years, if there is a malocclusion, there is an IMF for another 2 weeks. Okay, this is for 10 to 17 years. So this depends on the conservative, the type of age that you come across for this management. Okay, so why is the reason that we say only for 7 to 10 days for children is during their growth spurts or when their growth period is there, it is difficult to put an IMF for them and control the growth spurts over them. So sometimes it may lead into an ankylosis, and if you don't treat the children also on a proper fracture with a proper remedy over them, it could lead to ankylosis, TMJ ankylosis. So that is the reason that you don't take a long time for an IMF in a children, and you have only like 7 to 10 days, that is approximately 2 weeks. Okay, 1 week or 1.5 weeks, that is the maximum that you can go across for a children. So children, if it is like severely fractured or there's a situation that you need to operate, you can go to resorbable plates. It's very rarely that you go for resorbable plates. Otherwise, you can just do a simple IMF and reduce the fractures and just leave it off. So when you go for open reduction, what is the absolute indications for open reduction? So which is the absolute indication? Where in which case you need to operate compulsorily, okay, and there's no way for compromise for that. In those cases, it will be like displacement of condyle into the middle cranial fossa. Okay, when it is disturbing the middle cranial fossa, that time you need to operate. And in impossibility of obtaining adequate occlusion, where when you do an IMF or do an arch bar or whatever intermaxillary fixation you do, if you're not able to get the occlusion over that, then it is difficult for the patient. Patient may undergo a lot of pain and difficulty or swelling and discomfort over it. So that time you need to operate. Next, laterally displaced condyle fractures. Well, laterally displaced condyle fractures may impinge over the skin. It may injure it, or it may give an unaesthetic view of the facial region. So that time we need to operate. Or invasion of foreign body. Suppose when you hit a condyle fracture and you have some foreign body or anything over that in your thing, like maybe your a stick or stone or something which has been injured over that, or you have a glass piece over that time you need to operate over that. So these are the absolute indications. First I told you, when it is in the middle cranial fossa, when it is obtaining and when you are not able to get an occlusion, second thing. Third thing will be laterally displaced condyle fracture, when the condyle fracture is exactly laterally displaced. Okay, next, if there is an invasion of foreign body. So these are the absolute indication of an open reduction for a condyle fracture. So relative indications, what are the other indications that we use? That is like absolute, that is 100% you need to operate. Here there are, in these cases also you can operate, which gives a good result and it will be comfortable for the patient. Bilateral condyle fractures in an edentulous patient when IMF is not possible. Okay, so you have an edentulous patient where you cannot do any IMF. Okay, in those cases, when there is a bilateral condyle fracture, obviously you need to operate. Next is bilateral fracture versus or IMF is not recommended. Example for scissors, or there is a unilateral fracture or bilateral condyle fracture where there are certain cases where IMF is not indicated. Okay, it is contraindicated. Okay, you cannot put an IMF for these patients, specifically a patient with seizure disorders, a patient with an epileptic history, or a patient who is an epileptic or severe alcoholism or refractory behavior. Okay, what all happens in this case? Why do you need to not do an IFF in a seizure patient? So when an epileptic patient, suddenly if he gets an attack or he cannot communicate, or it is very difficult for him to do an emergency management, so it is not indicated for an epileptic patient. So what happened? So obviously for an epileptic patient, you take a proper fitness and you go for the surgery. Okay, then what will happen for severe alcoholism? Patients with severe alcoholism, they attempt to vomit, or they attempt to, when they are in the state of alcoholism, they attempt to do whatever they want. They may somehow pull up with their wire and throw it off, or they may fall again, or they may swallow something or wires or whatever it is. They may have a severe difficulty in swallowing or breathing. So many things will happen. So in these cases, so it is again contraindicated for them. So if the patient is alcoholic or something, you please don't advise him for an IMF for him. Next, refractory behavior, patient is like with the mentally retarded patient or something, they cannot manage this IMF. Okay, they can't, sometimes the patients, sometimes you tend to see a patient with them, they attempt to breathe over their mouth. Okay, so that is difficult, or they cannot eat their food or properly during their, you need to have a semicellular liquid food during the IMF. That will be very difficult for these patients. So it is better to operate all these patients. So bicondylar fracture with comminuted midface fracture. So there you have a midface, we have a bilateral condyle fracture and have a midface fracture. There's a difficult for the patient to aesthetic, difficult in airways. There's so many problems that you face, or patient's normal mouth opening itself will be difficult. So in these cases, you need to operate. Next, bilateral condyle fractures are associated with problems like multiple tooth loss, open bite, severe periodontal problems, retrognathia, prognathia. So all these cases, what will happen? Like you cannot do an IMF. So when there's no settlement of, like when you have your mandible fracture and you have not reduced it or not done any IMF, what will happen? It will have patient will have severe pain. Okay, severe pain will be there. There will be like stiff deformity, dislocation, difficulty in eating or difficulty in moving around or aesthetic. There's a lot of problems that they'll face. So in these cases also, it is advisable to better to operate. So what are the types of wirings that will come across? Okay, so transosseous wiring. So previously when the plates were introduced, they used this transosseous wiring. So there will be two segments of fracture. One there will be they'll use a burr and create a hole on both the segments and they tie a wire over it. This is called as transosseous wiring. So it was invented by Thoma in 1945. So intermedullary pins and screws. So what are the other methods that can be they use? They use intermaxillary medullary pins. Okay, they use a pin like structures which can be connecting the both segments, or they use the screws. They call like long screws which can connect they call the lag screws or something. So it's like when you connect both the segments, they usually use these type of wires or screws in the other fractures of our this thing, like our angle fracture on your hand or on your leg or something. They use these type of fracture, but these type of lag screws can be used at some type of fractures also. But nowadays they don't use this type of lag screws, as we have a lot of modern inventions that you have, right from mini plates, observable plates, and a lot of plates that you come across. So this thing is not necessary actually in this case, but you need to know like what were used when those days when these were not invented. So these are the plates that you come across, this type of plates, compression plates, mini plates. So there are a lot of types of plates that you come across. You can use various types of plates, where you can use like 2-hole plate, or you have lambda plates, or whatever type of specific plates for it, or 3-hole plates for that. So according to your type of management that you do. So surgical approaches, how do you approach this condylar region? So if it is a subcondylar region, it is difficult actually. Even a subcondylar region you can do it, but intraorally you have to do it, but it is too difficult in thing. But at the maximum, all prefer a condylar fracture, like open, like extraoral approach is best way to approach a condylar fracture. So they usually approach a preauricular approach. Okay, that is like you give a preauricular incision upstairs through it. That's the intraoral approach you commonly come across. You have use a trocar or something, and you can use a intraoral approach also. But very commonly when you go into extraoral, they use a preauricular incision. Then for complications, what are the type of complications that will come across? You have a delayed union and non-union. You will come across infections. Okay, when it's not treated properly or any foreign body is there, you will have a lot of infection over that particular area. Then malunion. Okay, if it is not reduced properly, there will be a malunion. There will be ankylosis. Again, if this fracture is not treated properly, it will lead into an ankylosis. So you have a lot of patients like in the young age, they attempt to fall from tree or they fall from cycle or something, but they are not treated properly. They just say it is a small fall, they don't find any bleeding outside, or a patient, the particular child may have a mild opening alone, they say like it's a temporary thing, so they leave off that. But later on, when you go on, when the age goes or anything, you find like their team just gets ankylosed. Okay, next is nerve injury. So there will be type of nerve injury. If during the nerve injuries, there are common complaints that will come across. Disturbance of normal growth pattern. Okay, this is because when the children is treated, and if it's not treated, it depends on they have a disturbance in the growth pattern. Okay, suppose they give a long plate or something, that may be disturbing the growth pattern. Next, obstructive apnea. So patient may come across sleep apnea. That is like obstructive apnea when there is bilateral condylar fractures are there, or if it is ankylosed, they have difficulty in breathing. They go into snoring or thing, that is called the ankylosis. So they go into obstructive sleep apnea at the particular stage, because this entire segment will get smaller, and what will happen, it will be pushing the trachea region, and it will get difficulty in sleeping or breathing through. Okay, so they attempt to breathe through their mouth. On conclusion, I just want to say what this condylar fracture says. Management of condylar fracture is a controversial topic with different opinions regarding closed and open method. That's why I told you there's always a two school of thoughts. A particular school of thought, or a particular set of people say that condylar fractures should not be opened. They just do an IMF and treat the other fractures, like accompanying other fractures, like it could be an angle or symphysis or parasymphysis, and just leave off. Just do an IMF for this. Now, other school of thought, they say, like you always open a condylar fracture. Okay, whether it is neck of the condyle or the subcondyle or whatever it is, whether it is lateral displacement, you need to open and take it. But it depends on what you decide and how you decide on. It differs from patient to patient. It differs from surgeon to surgeon and the different from a school of thoughts. Okay, it is always a controversy thing. In my limited experience, cases treated by closed method yielded excellent result. That according to me, I feel a closed method gave a better result when it is needed. But certain cases, it cannot, if you don't get an occlusion, whether I told you an absent condylar, in those cases, you need to open it. Okay. So, in the words of John Hunter, always surgery is like armed savage, attempting to acquire a force that which a thinker would acquire by strategies. So, it is not a matter of like immediately you need to go and open it up a particular area and do a surgery for everything. But there is, I don't say that you need not operate for all the cases, but you need to operate when there is a need. When there is no displacement or there is a fracture which cannot be approached totally the condyle has been out, or it is like medially inside or laterally over that area or anteroposteriorly behind, those regions, at the more that cases you need to do a simple closed method. I will not suggest an open method for that. But when it's indicated, need of indication is there, that time you use. Other times you do not go for it. So this is according to my little knowledge that I know. Okay. Thanks for this patient listening. Thank you so much. And I thank all the students for listening to my lecture patiently. Thank you.